not only with the Healthcare Task Force, but also, everybody in the room, the state, and everything else. The report is now online, so people can access it and start reviewing it themselves. Task Force members have a hard copy at their desk. But as John and his team walk through the report, we're going to hold off on questions from the task force and everyone else until John and his team has a chance to go through the report. We're going to break around 11:30 for lunch, and we'll come back at 1 p.m. If John has not completed going through the report, we'll have him finish that up at 1 p.m., and then we will begin asking questions. And the way we're going to do the questions is we're going to allow the task force members to ask the first batch of questions, and I don't know how long that's going to go, but we will definitely get to legislators who are not on the task force toward the end of the day. I envision that this meeting is going to last somewhere into the mid-afternoon, but if we get near 6 o'clock, I'm going to make 6 o'clock a hard stop time. We're not going to make any decisions on recommendations today. So I just want everyone to be really clear that we are not going to, as a task force, make decisions on any of the recommendations that are in this report today. Today is the unveiling of the report, the discussion of the report, and the beginning of the assessment and decision-making process. I realize people have not had a chance to go through the report, and there's absolutely zero intention to make any decisions about the recommendations in the report. Separately, the task force will be making 2 decisions on contract questions, but those will come up this afternoon. That's different, and it doesn't have anything to do with the decisions in the report. What we're going to then do is come back on October 20th. Questions raised today, questions that come up tomorrow, the next day, and the day after. For example, John and his people said 7 plus 7 is 14. I think 7 plus 7 is a different number. Here are the reasons why I think it's a different number, et cetera, et cetera. We're going to give everybody a chance, as best as we can, to get those kinds of questions vetted through together. And when we come back on the 20th, we'll address those things. I said tomato, you said tomata, what is the proper pronunciation, et cetera. We'll give everybody a chance to be heard and to have the consultant and his team respond to those kinds of questions. On October 20th, we'll come back, we'll have more questions and answers. We'll continue to hone in on the recommendations, the assessment of them, the question marks, and those types of things. We're also set to have another meeting on November 10th. I don't expect that we will really have resolved all these things by the end of October, so on October 10th is another opportunity to do the same thing. Where we're headed through the November 10th meeting, the November 24th meeting, is to start aligning on a recommendation platform flowing from what the Stevens Group is presenting to us, as well as potentially other recommendations that come from other places, so that by the time we get to our December 16th and 17th meeting, this task force will be voting on a final set of recommendations which will go into the task force report, which will be prepared and delivered to the legislature and the governor by the end of December. So that's the timeline, that's the decision set. People are going to get an opportunity to read and study and do all those things that we need to do. This is going to be as transparent a process as we can make it. And with that, I just turn it over to my co-chair, Senator Bledsoe.
I really don't have any special comments. Just want to thank you for being here, and I'm ready to go to work.
John, if you'd introduce yourself for the record, you're recognized to present the report.
Okay, John Steven from the Steven Group, and I just want to have each of my members introduce themselves first. Martha.
Steven Group.
Hi, I'm Rory Rickert, Steven Group.
Stephen Palmer.
Richard Kellogg. Jason Mellencamp.
Bob Chin.
Thank you. Mr. Chair and Madam Chair, I'm gonna make a few remarks, and then we'll go right to the PowerPoint presentation. I know this may be a long day, so I'm gonna go as quick as I can. There's a lot of information here, and I really appreciate the fact that we'll have time for a lot of questions, because we have our team here, and we want to be able to answer any questions that you have. It's been a lot of work on the ground, and it's been a great experience for us as well. I want to say that I understand, or we understand the seriousness of your work, and we appreciate that, and we know that, you are looking at making the best decision for the people of Arkansas and those that are served on the Medicaid program. We also recognize that much of this document, particularly the findings, is definitely in the weeds. And I'm looking at Senator Chesterfield because I tried to do my best to get you a very crisp executive summary, about 25 or so pages, of both the findings and the recommendations that I think will be very helpful. And the other issue is there's a glossary as well that's attached to the findings. Behind the findings is a glossary of almost every term that we used in here. We wanted to make sure you had a glossary so you could go back and check. So I think that will be really helpful.
So noted.
We've also looked at data, and I appreciate what Representative Collins says. From our perspective, it's critical that every member of this task force know, and the legislature understand, that our ability to analyze and assess this program is based a lot, in large part, on the data that were presented by the department, the carriers, and we looked at a lot of data. And during that time, it's been difficult. There's been some real difficult efforts to make sure we just get the data correct, and we've had to go back and forth. And there's no question that there's been some conflict at times in the data, and we had to go and have it explained to us. And we've learned a lot. We acknowledge that there could be other data sources out there. In fact, in this program, there's numerous data sources. And we expect that many groups may have a challenge with some of the data. But the bottom line here is we feel that we have done as thorough a job as possible in presenting you the picture that you need to be presented to make your decisions. And we also know that it's really important that you also look at the field work we did, because we were out in the field and we met with a lot of people. And we appreciate the fact that so many Arkansans came to us and gave us a lot of information and told us what they think from their perspective, what this program is all about and how it impacts people. And at the end of the day, our common denominator here is what is best for the person that you are asked to serve in Medicaid. It can't be about the provider, it can't be about the department, it can't be about everyone else. It has to be about that person. So we always look back to what's best. And we know that your charge was to come up with that best solution. That was in the RFP. So the Volume 1 findings may seem very voluminous, and there's a lot of issues there. But it's really making sure that we are able to address everything that you asked us to do in that RFP. So that's what that Volume 1 findings document is all about. And from there, we come up with our recommendations as a team and what we think you ought to look at. But at the end of the day, it's your decision. And we want to be here to help you in any way, whatever decision you come up with, and be able to answer your questions so that when the policy has to be decided here, that you are armed with the information you need to make those decisions. And that's our goal. I also want to say that any replacement of the private option must be looked at to address healthcare disparities and education and making sure that there's a ladder of opportunity here for individuals that are not working, that could be working with a little help. And also educating folks to know what it's about to have health care. Because we have found there are issues out there in the community regarding information that they're getting and information that they know about and where to access care. We believe that you need to make decisions, obviously, on the private option, but we are going to hopefully give you some ideas and thoughts today. But it's the people, again, that you're asked to serve that we want you to think about. We believe today that Medicaid, traditional Medicaid, offers payments for services, but not for value. We strongly feel that the focus needs to shift from simply paying providers, but instead focus on outcomes. We've seen this in other states, and we know you can do the same. We know you can. From top to bottom, the entire program must shift its focus from paying claims to improving health care for Arkansas citizens. We've laid out several pathways to improving the quality of Medicaid while making it more affordable and sustainable. And we believe that's the case for years to come. Each of the paths have their own positives and negatives. In fact, some of the task force members came up to me this morning and had some concerns with issues, and others they liked. Not everyone's going to be happy here, including the folks behind us. But again, we're looking at it from the perspective of what's best for the individual, what's best for the taxpayers, and what's best for the program overall. We truly want to thank the many agencies and groups and individuals, Director Seelig and his staff, that were so helpful and collaborative in making sure we get the information for you that we have today. Finally, I want to thank the task force. You've demonstrated your concern for ensuring the best interests of the future of Arkansans for years to come. And the time that you have given to this is unquestionably so fantastic and not like other states that we have seen. Many states go through reforms, but they don't do it in a way that's methodical, that involves the legislative body really thinking first before they act on legislation. And I really appreciate the fact that you're all very much involved in this process. So we thank you, and with that, I'm going to move to the presentation, and we're going to go through our presentation today. And the agenda for our presentation is as follows. We're going to summarize some of the key, and I mentioned the word key, private option findings, the Healthcare Improvement Program findings. We've already gone over a lot of them during hearings, but there's some folks that may not have seen everything or been here. I want to just make sure we highlight the significant findings, all in the report. I want to then move and transition into significant findings for traditional Medicaid. And then we want to talk about the fiscal impact of the private option, and we're going to refer to it as private option. And we want to be able to provide the significant financial impact so that you could be prepared to make your decision. And maybe there are issues in that financial impact and how we've arrived at it that you may not even agree with. That's fine. But we're going to give you an explanation of what we came up with and why we came up with what we did. We are then going to offer our recommendations. The recommendations are going to be the private option. We're going to give you what we said an in-the-box recommendation based on what we believe CMS is willing to accept, what we have heard from the governor from his meeting with the secretary, what we have read and what we know from our own experience, what has been accepted or what has been at least alluded to being acceptable to CMS. We are then going to give you an out-of-the-box solution that is possibly one that may have to wait till the next administration. But we feel it's very important that you hear these solutions from us. The final thing we will tell you is the traditional program and what we think needs to happen in traditional Medicaid. Again, to bring better value, to bring good outcomes. And then we'll talk about some of these savings estimates. In the end of today, you're going to get some of our savings estimates based upon the program if you were to accept a number of these recommendations. And these, again, I'm going to use the word estimates. We're working on a lot of moving parts, and we're going to tell you what our assumptions are based on, and we will also provide you evidence from other states, because we tried to work really hard to get demonstrable evidence of what has happened in other states so that we can give you at least a benchmark and a baseline that we feel is reasonable. And that's what we've done today. So the first issue is summarizing the key private option findings. 250,000 newly eligibles. Roughly estimate between 225,000 private option at the time we looked at the data and 25,000 plus or minus medically frail. The medically frail are in the fee-for-service program. They have a choice, actually, but most of them choose to go into the fee-for-service program. The participants, 80% of the are enrolled in the marketplace. The private option participants are younger and thus healthier and lower cost. 65% are under 45 years of age compared to 45% in the marketplace. The private option participants have access to substantially more, many more providers than in the fee-for-service system. The private option participants utilize emergency room services at a rate higher than Medicaid. And that's an interesting finding, and we're going to talk about that in our recommendations. Health disparities we talked about earlier. There's a lack of understanding out there in how to utilize the system, and there are concerns from the community. There are no incentives, I'll stress, no incentives for utilizing appropriate care. Let me step back. One of the carriers actually did offer some incentives with dental and vision and other areas, but there's really no systemic incentive for appropriate use of care. $9 billion of additional federal match payments over the next 5 years. Actually, it's 2017 to 2021. And that's kind of what we modeled. $9 billion in additional federal dollars. Uncompensated care has dropped dramatically in the first year of private option, and it has played a significant role in dropping uncompensated care. But I want to note here, too, is that subsidies from 138% to 400% have also played a role in uncompensated care. So it should not be left the impression that uncompensated care has gone down because of private option alone. There's a lot of other factors to play here. The rate of uninsured among the non-elderly adults has dropped in your state very significantly, as you can see, 27.5% to 15.6%. Many in the private option are not working. 40% have approximately 40% zero income. And that is from data the department gave us from an analysis they did in October of last year. And that was what they had said, and we have reason to believe, not anything different than what it is today. 15% are between your 100 to 138% FPL, and not much different than what you're seeing in other states. The average claims to premiums is 79% below the MLR and ACA. This has been a success in terms of the rate. Physician licenses have not been impacted. We've had our physician survey, by the way, is attached to the appendices in your report, the complete survey. We ended up getting somewhere over 400 responses, which we thought was pretty good. Thanks to the task force, it really moved up after our first meeting. The state health independence accounts are not showing great success. 45,839 cards issued and only 10,806 are activated. Only 2,500 individuals contributing monthly. If Arkansas rejects Medicaid and returns the program status prior to 2014, the net impact to the state budget over that time period is about $438 million. We've already shown you the slide and identified why. You've got some cost shifting issues as well. And I want to, again, note, this takes into account that you want to continue those programs. This takes into account that you'll continue to fill the budget on uncompensated care. It takes those issues into account. The state may have options available to limit that impact, and that's what I'm alluding to if you decide you don't want to take those issues into consideration. So let's shift to traditional Medicaid. The Arkansas Medicaid program is on an unsustainable path. We are using conservative growth estimates of 5% a year. Remember, 5.9% is what CMS is using for the next 5 years. And we're going to show you a chart in a minute here on the path. And yes, there's been a decline in the growth in the past couple years. A lot of that is in respect to the fact that the private option folks have shifted from your program and the economy and other issues. And we don't think you can continue to do that. But that downshift in your program over the past couple years, remember it was like, I think 8 or 9% a few years ago, has not been a result, in large part, of innovations and things that your department has done to really bend that curve. And that's something that we want to make sure we stress. But give the department a lot of credit, in our opinions, on the payment improvement initiatives and continuously trying to bring payment improvement initiatives into high-cost settings and continuously being stopped either through meetings or other issues that, we have seen in the community. Between now and 2021, general revenue portion to fund traditional Medicaid will grow by about $500 million under that 5% growth. $500 million. Currently, the state has not implemented best practices, as we've talked about. Your hospital payment initiatives are not based on value and risk. We've had a meeting with the Hospital Association, with Children's Hospital, and with UAMS, and there have been some difficult discussions there. Some of you may hear about them. But you know what? At the end of the day, they all recognize the same issue and are willing to sit at the table and to come up with something that meets your goal that's more value in risk and reward. And that's what other states have done. Care management strategies based on full risk, particularly involving managed care for aged, blind, and disabled, and other high-cost populations has not happened. And we've talked about this. And when we say ABD, it's just our term for like long-term support services and all the aged, behavioral health, and also developmentally disabled. So that's just a term that's used nationally. So, but here is the issue. With the ABD population and the payment structure, that's going to grow with the aged population at a higher rate. And so you need to confront those issues. And that's where a lot of our recommendations are going. And when we start talking later on about managed care and patient-centered medical home, we talk about, and I think I said this at the second meeting, when you hear managed care, just be careful and step back. This is all about care management. This isn't just about managed care being capitated full risk. Patient-centered medical home is managed care. It's all care management strategies that other states have adopted, some for long periods of time, and most with success. So remember that. That's a very important point. 3/4 of the traditional Medicaid expenditures on ABD population. We met with the department just the other day on the 74% figure that we told you on the age, blind, and disabled costs. There was some additional costs that we weren't given during the data set that were in some of the lower cost population. So that number may be down even a little lower, but it's still 70 to 74%. And it's in that high cost area. So the bottom line here is, no matter what you look at, significant amount of your costs are in the age, blind, and disabled area, which you have to address, in our opinion. Currently, there's no independent assessment for age, blind, and disabled populations. Richard will talk later about where you're going and some of our recommendations. Overly high utilization of nursing home and other institutional settings. We've talked about that at length. And there are barriers to community-based care that are not existing in other states that we have learned during the way, and we've identified some of them for you in the recommendations. And if you start lifting some of those barriers, you're going to start really seeing differences in focus of real community-based care. And nursing homes should be a part of that. They should be at the table and be very willing to work with you. Because if it works for the community, it should work for them too. And it will. I visit my 96-year-old grandmother in a nursing home every Saturday morning. And you know what? It's the best quality care, and it's where she needs to be. But she was in the community for a long time leading up to that point. The state has not been successful in rebalancing long-term care. AARP survey has shown 91% of Arkansans support home and community-based care. We've cited that survey here for you. 2,900 now are on the DD wait list, but 91% of them are receiving something from Medicaid. So it's not like they're just receiving nothing. There is a small amount that are receiving no services. And you need to address that, and we're going to give you some ideas. Behavioral health system, highly siloed and fragmented. We've talked about that at length. We've given you a lot of information. Absolute ability to improve that area. Patient-centered medical homes showing promise in improving outcomes, avoiding costs, and leading to better access. Episodes of care, national best practice. But the ROI, we're not clear exactly whether or not it's in your best interest in terms of, is it the rate you need to really take care of some of the other needs in the population? And maybe there ought to be just a different focus. But again, give the department credit, in our opinion. Healthcare payment improvement initiatives. Patient-centered medical homes. 19.7 million in direct Medicaid cost avoidance compared to benchmark trend. And this data, by the way, has been updated as of Sunday. I received an email from the department because I've been asking them for a while to give me the most recent patient-centered medical home data numbers for the committee. Those recent numbers were given to me on Sunday after the final report, and Stevens looked at those so he can address them, and they're even a little better than what these numbers are. 12.1 million used to fund foundational investments in primary care, 7.6 million to be shared between state and providers, 78% of quality measures improved or maintained for Medicaid enrolled practices, including reduced hospital stays and emergency room visits. 100% of enrolled beneficiaries with 24/7 phone access to their primary care practice. And looking at some of the financial estimates for the episodes, and Stephen has talked a lot about this, and the development costs at 43 million, actual maintenance costs, annual savings anywhere from 8.7 to $20 million in our estimate. Further, traditional Medicaid, the state has atypical high cost for traditional, and this was something that you asked us to compare your costs to other states, and we did. And clear to us, you're on the higher end when you compare to other states. 4 of your neighbors, Tennessee, Mississippi, Texas, and nearby Kansas, all utilize full risk managed care for aspects of the whole population, but predominantly high-cost population. We're going to talk to you about some of their results. But all 4 have significantly bent the cost curve. They've improved access and quality care. We've also spoken to every state leader in those states and their staff, and they provided us with data from their departments. And we've looked at the data, and we've analyzed it. We've looked at a Milliman report, which is an independent report, and we have all that data for you. Texas has saved over $3.8 billion since fiscal year 2010, and they're on a trajectory path of $7.1 billion, and CMS is actually looking at that state as a best practice in this area. And yesterday, I was speaking to Texas officials that were talking about, the money that they save, looking at a potential waiver to see if CMS would let them use some of those funds later on in the future in some of their program. Kansas reduced spending from 7.5 to 5% the first 2 years. They used $60 million of general fund for the wait list of those savings, which was matched with federal about $140 million. And they targeted their savings in their law, they targeted a lot towards the wait list. And it's now gone. It's been used. The Tennessee, significant reduction in long-term care. Every one of these state leaders, by the way, very willing to come here and testify and provide assistance for you in any way. Summary, organization at DHS, overly siloed. Staffing models lead to excessive use of consultants. We've shown you a lot of the reports. And when we get to our recommendations, a few of my team are going to be able to address some of these issues that they've seen when they state some of their recommendations. There's a lack of an integration and organization model between divisions responsible for high-cost care. We'll show you the organization structure, and you'll be able to see what we're talking about. And we're giving you an idea on an organizational structure that could even have greater integration than some other states have used. For example, long-term care, aging, behavioral health, development disability, all have different division directors, and they're all in different silos. They just started meeting together, or they've been meeting on an ad hoc basis, but they just started really having good, quality-based, regular meetings together with the directors. And in some states that have succeeded, they've created a division of community-based care and it's all been integrated in one division. So when you're looking at waivers and you're looking at programs, if someone's calling with a development disability issue and they also have a behavioral health issue, you don't need to shift from division to division. And we've offered some suggestions there. Collaboration across the entire organization is lacking, particularly in the areas of care coordination, program integrity, procurement, and shared services. And again, I believe Director Seelig has told you about a lot of the different silos and areas, and I know that they're looking at addressing some of these. And especially, you know, there's some good things here where Medicaid Inspector General working with Department of Human Services on a what's called Advanced Planning document, which we're going to talk about for an enterprise data-based data analytics program, working well together, and that can continue in the future. So one of the organization structures you have, if you look at this slide, and I know it's in your findings, but just looking at the slide is what kind of emblematic of what I'm trying to say here. Our team saw, and Martha and Richard and others that look really closely at organizations around the country saw right away that you have a Medicaid director who does a great job, in our opinion. But you have a Medicaid director who really is a separate division than aging, separate than behavioral health, and separate than DD. And that's just how the organization structure has been functionally managed. And that can change, but just changing your organization structure is not going to change everything, but it could help. And there are other issues with that structure. There's no centralized vendor management function or unit. There are very few people with the availability to write RFPs because they're working on so many different issues, and when it comes time to write the RFP because the timeline's up, they're working on it sometimes at the last minute, but yet doing the best they can, but they don't have a lot of good, resources that really are geared towards effectively writing RFPs. So what do? They outsource a lot, or they want to outsource a lot. So there needs to be some discussion there about helping them with resources in the future. Procurement timeline is very lengthy. Other states have managed this well, and Martha will talk about that in the recommendations. There's a lack of number of resources that are significant with skills to negotiate. If you move to a more value-based contractual system, you move to managed care, capitated full risk, or patient-centered medical home, or David Norsworthy's idea on the value-based to nursing homes, you've got to write contracts. You've got to now have some people sitting at the table and saying on behalf of the taxpayers of the state, no, it's not going to happen that way. We're going to do it this way. Or, yeah, that's a great idea. Let's figure out another way, and we'll reward you for X, Y, and Z, as long as these performance metrics are met, as long as these issues. You need, and there are folks that understand these issues, but when it comes to, especially if you decide to go full managed care, to be able to negotiate, you want to make sure you provide them the resources they need to effectively negotiate on your and the taxpayer's behalf and the state's behalf. And strong examples of specific deliverables and consequences for missing deadlines we have seen. We have seen project management. We have seen strong deliverables at the department. We have seen them in certain areas. There are other areas where it may be scaled back or something may happen because they're not effectively project managing from the beginning. And we'll talk to you about a systems integrator issue with EEF. But by and large, on these contracts, they are holding people to their feet to the fire on the metrics that are in there. But they do need to have the resources to really upgrade these contracts on value in the future. Legislative review process is lengthy and broadly. I know that this is not probably comfortable for some of you. We did a project in Texas on child welfare, very similar. And the Texas legislature continuously was passing statutes on, dealing with health of children and safety is so important to everyone. But there were so many laws that have been passed over the past few years, and the state workers were all over the place, not really getting a coordinated, clear vision. The approval process for any rule change, even an idea that's going to come out of of this needs to be looked at to be streamlined. The definition of a rule at the department is overly broad. And maybe that's what you want, and you want that type of management, and maybe there's a history there that it needs to be that way. But try to figure out really how to streamline this. And there may, a 30-day, I need a 45-day review process from this committee before it can go to this other committee. That 45 days may be a time that some family can get help. And really important to think about that when you go forward. And I know how critical it is. My dad was in a state senate for years, and I know it's important to everyone. But just think of how important it is to consumers to make the decisions as streamlined as possible. Additional committee review, we've talked about that. We're going to give some thoughts to that as well in the recommendations. The traditional and the private option convergence to MAGI, this is the adjusted gross income level from the federal government. The new ACA standard was very difficult for all states. And it was coupled with an effort to convert this new software, eligibility software here, and it's led to significant obstacles that you all are aware of. And we're going to talk about some of that in our recommendations. The lack of real-time checks on applicants' identity, assets, addresses could lead to the possibility of ineligible individuals receiving Medicaid. Now, I want to go over this issue on the scrub because we did complete the scrub. It's in your report, but I want to highlight for everyone, this does not mean that we found fraud. And we need to be clear on that. These are risk indicators. But the risk indicators that were found absolutely convince us that you have a problem that needs to be addressed. There are folks that are out of state, in our opinion, based on the data, that could have legitimately moved out of state, are not telling the department, and you're paying a PMPM every month to a carrier because you're not checking routinely if someone's moved. And whether there's a claim or not, the carrier's still getting paid. There could be folks that are taking advantage of your expansion that are living out of state. Could be. Our scrub was able to flag and identify a number of out-of-state addresses. Traditional Medicaid, 22,781 had what we call the best address. That was not an Arkansas address. 20,110 in the private option had the best address, which was not an Arkansas address. Now, what does that mean? That means that, again, the best address was most of them had an out-of-state address before they became eligible. Could they have moved into the state? Possibly. But what the subcontractor has looked at in the databases they have, the largest in the nation, they also provide data to your state police on identity and address. And they use credit checks from Experian, Equifax, TransUnion. No different than the credit checks that you all have. They use government sources, driver's license data from every state that they are able to obtain. They also have utility data. When you're even in the low-income area you're going and you're renting, you've got a utility bill, mostly. And they're able to get that information on public databases, and they put it in to their own database, and they have unique identifiers for every individual that they have of Social Securities. Here's why we think it's a problem. You had out of the private option, you had I believe it was like 220,000. We'll look at the numbers and the findings. No matter what, it was like 96 to 97% accuracy in terms of that person being in their database. With the traditional Medicaid, same thing. High number in terms of percentage of folks, which was really interesting because they thought it would be a lot of people on your private option and traditional Medicaid may not be in their database. But it was almost 98 to 99%. So they took that information and they were able to find addresses out of state. They were able to find real property. It was individuals on the private, a few individuals on private option that had property well over $100,000, assets. One had a home and it's anecdotal, but it's still an issue. One had a home valued somewhere more than $500,000. And then these are all matching Social Security with date of birth, name, and again, risk indicators. So what does that mean? You need to, if you want to, and I said this to you early on when we talked about the scrub, and I think Representative Hammer asked that question. These are issues you have to investigate now. And do you want to look at it? Do you want to spend the time and resources investigating versus fixing it on the front end so that you can make sure and ensure that public integrity going forward? And we're going to give you some recommendations about that. But the list that we were, by contract, asked to provide to the department has been provided to the department. So Director Seeley can work with Inspector General Elizabeth Smith, whatever you guys decide. But at the end of the day, we're urging you to look forward here. It is an issue, let's fix it. And we think we've got some ideas for you. Private option plans control underlying drug costs and dispensing fees better than Department of Human Services. Department of Human Services has opportunities to better manage opioid use, and I know Rory's going to talk about some of this when we get to the recommendations. Pharmacy claim limits are not using best practice. PDL is unnecessarily low, or narrow actually, narrow. And contracts have too many call centers, and maybe there's a way to integrate to help you there. DHS does not have robust provider audit capacity. Just billing alone, there were a couple questions we asked about billing. Nursing home sends in bills for a per diem rate, or bills for their rate. Bills stack up, invoices are paid. Who's checking to make sure that that individual is actually billed properly? And it's not that they're not wanting to do it, there's not a lot of resources there. So let's think about really providing them with good resources on auditing capacity going forward if you really want to improve the program. OMIG statutory mission goes beyond fraud. This is an important issue. It goes to identifying abuse as well. And that's a vision to us that was crystal clear when we met with OMIG. They get it. They need resources, but they get it. OMIG doesn't have innovative tools that other states have. They don't have the pattern type technology to look at whether or not billings have been done correctly, whether there's again, risk factors that they ought to look at. They don't have a lot of that, and they're trying to get that technology. But DHS has a vendor that has that capability who's providing some level of small support. But there's not what we've seen in other states where robust data analytics on public integrity. And then when you compare your recoveries to what the recoveries are nationally, very much on the low end. And it's not because of lack of effort. Tools, really innovative tools are out there and available that could be used. This is something that we feel we feel it's a very important point. I'm going to stress healthcare value. I'm going to talk a lot about healthcare value. I want to give credit to Dr. Ron at UAMS. He used that phrase, best in the SEC, and I hope he gives us at least permission. We used it without asking him for permission, but we used it, and we quoted him. But what a wonderful thing to think about, to have your healthcare status improved to be best in the SEC. Can you do it? Absolutely. Absolutely, without question. We think so. But there's little emphasis on healthcare value here in this state from the department. There's a lot of players, community providers, primary care physicians on our survey. They all want to contribute and will help. Everybody should be working together. But improving healthcare status in Medicaid has to happen. And there's other departments, again, involved. And we're going to give you some thoughts and ideas on how to improve, how to just benchmark and be able to at least provide you with the information that you need to really see, is it working? Are immunizations going up? Are mammogram percentages going up in the program? Today, you don't have that data, and yet you're paying all those bills. Findings, to recap. Arkansas has a typically high cost of Medicaid compared to other states. Tremendous opportunity to improve. That should be the highlight here. And health outcomes, care coordination, vendor management, public integrity, organization, efficiency for taxpayers, all of it. But again, come back to the one focus point, and that's the consumer. So I'm going to hand it over to Steve on this particular slide. This is an important slide because it's showing you where the program is going in the next few years if you use that 5% trend. Go ahead, Stephen.
Thank you. So we're on slide 20 here. This shows several different projections of Medicaid growth rates at under different growth assumptions. The top block of numbers represents several different growth assumptions for all funds, and the bottom block is for state general revenue. You'll note in the bottom block, the top line there is the 5% growth assumption. Currently for 2015, you're at about 1.5 billion for general fund contribution for the state match. Looking out with that 5% growth rate to 2021, you're at about 2.1 billion for the state match.
Okay. And I think I've already raised this slide, and we've talked about outcomes and health status on slide 21. I want to see if there's anything different. No. Go ahead, Stephen. This is the impact on the private option.
And now we're on slide 22. This slide is similar to slide 20 in that it is a projection of expenditures associated with, in this case, it is with the private option. The top line is the federal match for the PO. That's just to give a sense of the amount of additional federal money associated with maintaining the PO or something like it over that period. That grows from, in 2017, at about 1.7 billion up through about 1.9 billion in 2021 for a total aggregate over those years of almost $9 billion. And then the next two lines are the impact on state funds from removing the PO and or not replacing it with something at least largely similar. In the early years, there is a negative impact on the state fund. That is to say, if the PO is removed for those first several years, you will have to fill in with additional state funds because the expenditures there will be new expenditures back on the traditional Medicaid side that had shifted over to the PO. And then there's also the loss of premium tax and replenishment of direct uncompensated care appropriations. In the bottom line, that does not take into account the macroeconomic effect or restoration of state-funded uncompensated care. And so in that second line, the 5-year impact on state funds is a negative about 80 billion. And if we do not take into account the macroeconomic effect or restoration of state-funded uncompensated care, it's a positive 125 million over those 5 years. Going on to slide 23, this is capturing other impacts of the private option. These data are projections based on survey data that came from the Hospital Association. This is the impact on hospital uncompensated care over these 5 years. As John mentioned, the private option is not the only thing that is driving the uncompensated care costs, but based on the number of people enrolled through the PO versus in the marketplace otherwise, the bulk of this can reasonably be attributed to the private option. With the private option, we project that there will be about 740 million in uncompensated care paid for or borne by the hospitals. Without the private option, that number is about 1.8 billion. And so the difference, the marginal impact of that additional uncompensated care borne by the hospitals over those 5 years is projected to be about $1 billion. Moving on to slide 24, again, here we're looking at the impact of other ACA-related changes. As you all are probably aware, the Medicaid expansion was not the only only impact of the Affordable Care Act. There were a number of other impacts on the healthcare sector on the financial side that were driven by the Affordable Care Act. These are not things that are in the state's control, but these are things that affect the Arkansas healthcare economy. So it's important to understand that these are additional changes that occurred at the same time that the Medicaid expansion was authorized. The first major line there is an increase in additional federal funds flowing to the into Arkansas due to the exchange subsidies. These are the subsidies that John mentioned, between 138 to 400%, mostly for individuals buying through the state marketplace. That represents a positive impact on the state healthcare economy of about $5 billion over those 5 years. The second line there is a decrease in federal funds flowing into Arkansas due to primarily taxes and rate cuts that were instituted as part of the Affordable Care Act. The rate cuts are mostly on the hospital side through the disproportionate share hospital programs through both Medicare and Medicaid. And then there are also some taxes in there, some on health plans, some on medical devices. That represents a net decrease in funds flowing into Arkansas through federal programs of about $10 billion over those 5 years. And the net of those is about a negative $5 billion. That does not take into account any positive impact from the private option or alternatives. And finally, on slide 25, this is the economic impact of the Affordable Care Act. These are projections based on analysis done by the RAND Corporation of the net impact of the Affordable Care Act on Arkansas. This does assume a Medicaid expansion or something like it for a net impact of about $3 billion on the economy over those 5 years, and annually about between 6,500 and 8,000 jobs funded by that level of economic impact.
So we're going to move now into the recommendations. And I want to highlight 3 major key themes of the recommendations. One is to bring personal responsibility, wellness, accountability, and focus on transition and promoting that quote-unquote ladder of opportunity, meaningful work engagement in the private option. We're going to talk about recommendations on improving the program. But it's really this thing about the ladder of opportunity. I want to give credit to Senator Hendren because I'm quoting and I'm using his term, ladder of opportunity. It was during one meeting. He mentioned to me, can't we find a ladder of opportunity? And that just stuck with our team. Traditional Medicaid, choose one of 2 overreaching or overarching directions, 1 or 2. And these decisions involve a lot of decisions in between and after, but really 2 decisions. Expand care management through patient-centered medical homes, episodes of care, and health home models with risk, reward, and accountability for outcomes for all populations, including elderly, and those with developmental disability and persistent serious mental illness. That's one option. The other option is to use private sector to bring managed care to all Medicaid beneficiaries, or at the minimum, the high-cost beneficiaries. So you really, in our opinion, those are your 2 options available that we would like you to pursue, to look at. And within those are a lot of different ideas too. But trying to bring it to is as what we think as global a decision-making as possible. Third, enhance the eligibility and program integrity across the entire Medicaid enterprise. Clear opportunities there. And those are your 3 really key themes that our team used in coming up with the recommendations for you. So let's talk about the private option, the healthcare improvement program reform. Here are key principles of our reform recommendations. Provide health care access and services for low-income Arkansans across the state. Move residents from assistance to independence and create that ladder of opportunity and readiness for beneficiaries, the foundation of which would be obtaining employment that leads out of government services. And we'll be talking about the TANF program, which has shown a success in your state and others. A commitment to wellness that is built around the notion of residents taking personal responsibility for their health based on increased health literacy and education. Improving the quality of care from providers through accountability to achieve measurable performance advances. working to ensure that the medically frail obtain health screening and prevention services, enhancing program integrity within the alternative to reduce waste, fraud, and abuse, delivering accountability to beneficiaries, providers, carriers, and taxpayers, reducing the impact on uncompensated care on health care costs, ensuring that all parties commit to provide the right care in the right setting to reduce inappropriate use of high institutional care, whether it's emergency room, nursing home, or development disability centers. Providing incentives to encourage healthcare providers to achieve measurable performance and outcomes and bring transparent scorecards for the carriers. So we're calling this recommendation, which is in the box, we call it THIP, Transitional Health Independence Program. Create a program emphasizing wellness, work readiness, and personal responsibility. Enhance eligibility verification process. Mandatory health insurance premium program for employees with wraparound benefit. We'll talk about that. Enhance cost shares for beneficiaries with substantial assets. End the healthcare independence accounts. May have been a good idea, but it's not working. Mandate work referral and engagement. Mandate work referral and engagement. And that's something the governor spoke to you about as well. We'll address his points. Promote quality and transparency among carriers and with publicly available health scorecards and ratings. Reduce health disparities through education and training. And again, the medically frail, proper care coordination. Employer support for those who transition into ESI, employer support insurance. Membership agreement required to promote accountability among beneficiaries. Create a wellness report card for enrollees managed by carriers. Offer vision and dental, which is not offered today, for those meeting all program goals. Co-payment and incentivize appropriate utilization of care. We're continuing, and all these are detailed in the recommendations. Create a member lockout for those who do not comply with wellness and do not pay premiums as a result of non-compliance with wellness. The lockout, by the way, is approved already in the state of Indiana. It is a way Indiana has used to encourage people to do the payments of premiums. We're looking at it differently. We are encouraging you to require the member agreement signed with a wellness agreement, visit to the primary care physician within the first 90 days, meeting proper, agree to HEDIS measures, whatever the carriers in the state or what you want to put in the legislation would agree to. But if you don't meet those agreements, if you decide, no, I'm not going to do this, then you're going to pay the premium. If you're going to comply with this, you're not going to have that premium payment. You're not going to have that type of cost share that others have. But for the inappropriate use of ER and inappropriate use of settings, there should be a co-payment for all, shared, up to the amount that within that 2% that's required by federal law. And again, incentivize this population. Or limit the 90-day retroactivity requirement. Today, the states of New Hampshire, Indiana, I think one other state have already received that waiver. When you sign up for the private option, your health care benefits would be taken care of, even if you're in between and you're waiting for eligibility, but you signed up, you would get the benefit of being covered, so long as you meet those goals and you're not in that lockout period. But today, you cover benefits that could have occurred 90 days before they even signed up. And that's about, I think we looked at some of the costs, somewhere around $10 to $12 million a year. And we have that all for you in the findings. And we're recommending that you do what some of these other states have done and ask CMS to waive that requirement. Allow an exit from the waiver with 30-day notice to give the state the ability to adjust if there's federal changes in the program. This could be an amendment clause in your waiver. There's been this, we've done this in other states, but you're going to have a new administration, and there may be changes, and you want to be one of the first states to be able to get changes that you agree with and not be bound to something longer term. Create legislative oversight that monitors outcomes and approves the program, approves significant policy changes, So this is what we're calling our THIP, Transitional Health Independence. Again, key would be the membership agreements. Carriers are able to do a lot more. Instead of the health independence account, the carriers can be the ones that have the wellness report cards. The carriers can be the ones that are audited to make sure they're complying with the rules that you set. And hold them accountable to come to you with benchmarks and scorecards of what that population is doing and what you're seeing. Have the oversight. And hopefully help individuals transition to good, meaningful employment. If you're between 100 and 138 FPL, you could be in a full-time job being paid minimum wage. But you could be right close to getting out of that 138 area, and you want to be able to help them transition too. But if that person is meeting their health goals, they're going to now be ready for that employer-based support. But they should get the benefit as well as anyone else to any type of additional work engagement or additional work. But the ones that aren't working, that need work engagement skills, life skills, and I know that Senator Irwin showed me this bill on you having University of Arkansas, I believe it's the agriculture division, helping the department with life skills training and helping individuals. Use some of those resources. But if they are going to work engagement and moving up, the whole point is to move up that ladder and help them. It can happen. But let me just say one thing with work engagement. I've talked to your Department of Workforce. In January, I believe they're going to be getting 50,000 of your SNAP eligible individuals. A new caseload, 50,000. We are suggesting that you look at like the state of Mississippi across the border that uses NSPARC at Mississippi State to do a lot of this automated and able to do all the verifications, and they have a great system set up, and they have all the jobs that are available online. Don't make it too complicated. But is Department of Workforce going to need new employees? You bet. If you were to go down this road, they're going to need help and resources. But again, you're paying $8 million for a health improvement, a health independence plan program that's not working. You have available options. And work engagement can work. And don't take the excuse that, oh my God, there's so many people and we can't handle this. Other states have done it and have done it well. And one other thing I'd like to highlight here on benchmarking. Don't only look at this program as benchmarking. Benchmark throughout the whole program. And I think that that's something that in the Medicaid managed care will do, or patient-centered medical home will do, and the department can do for you. The next, and this is in the box, the next recommendation would be what we're calling out of the box. And we are suggesting that you look at this solution in 2017 with the new administration. Might be something you want to look at. And we've been asked by some task force members to go beyond the box, to look at what could work. And we're just providing you with some ideas and solution or recommendations. A lot of similarities, a lot. Enhance the eligibility process. Create a program emphasizing wellness and work readiness. Member agreement, lockout and retroactively waiver provision. Quality scorecards, enhance cost share, health disparities, streamline the redetermination process, care coordination and evaluation for the medically frail. I didn't say enough about that. Today, and it's in our findings, you can look at the form. I actually, in the recommendations, put an appendix, the form that they're using today, so you can get a chance to see what questions they're asked to become medically frail. This is all self-report. A few other states use clinicians. You have to get a doctor's agreement, and there's some issues there. It may take some time, but our thought is, if you want to promote care coordination and you really want to get the frail individuals into the proper medical setting and get them what they need, you ought to be requiring them to do what Indiana and some of these other states are doing, to fill out a form, and it goes to a physician, and you have to be seen by a physician. You're still going to be covered, but you have to be immediately seen by a physician, and that physician will make the ultimate decision on frailty, very much like your disability determination process. Vision and dental. I do want to say, if you do your membership card agreement, if you're really trying to make sure you improve your health outcomes, you ought to be given the benefit of the vision and dental services that we think at a lower cost, and I've asked one of the carriers, it might be $20 or less in terms of the PMPM costs. But if you look at this whole program and you identify good practices, you will make that up in the savings. But vision and dental should be available to those that meet these benchmarks. Those are important benefits. And it has worked with one of the carriers when they were able to offer it. And if you don't do this, then you should not be offered those benefits if you don't meet the requirements. So we're calling out of the box work first. Again, very similar ladder of opportunity, promoting and focusing on work, meaningful work engagement. If you are above 138 and you're in the market, you've already receiving subsidy help, and you're going to get assistance. And we know that that's our goal here. But we looked at the TANF program here in your state and others. The TANF program across the country has worked. Everyone will tell you it's a program that has worked. And in your state, you also have employees that have used Department of Workforce does all the work engagement for TANF, not DHS. So it's easier to use them to do the same work engagement if you were to move in this direction down the road. The exception for work requirement only is for an active job search, training, or for those that are clinically frail, would be able to be exempted under hardship, which is, again, TANF-related rules. Wraparound services for 100 to 138. So the 100 to 138 would buy a policy on the exchange, would basically buy a policy and go on the exchange. They would be covered, the wraparound would be covered, but they would not be in Medicaid from 100 to 138. The state would provide the wraparound, again, provided they were meeting these requirements. And I put the price of some of the policies at 100%. You'd have some premiums. In Work First, you're going to require premiums, and you could have the same agreement waivers with meeting benchmarks. But you want to be able to have some premium built in so someone's getting used to paying, because when they get to that 138, more than 138, they're going to be paying on the market. So you'd have a sliding scale premium. Like TANF, the state, and this is an option, you could have a benefit time limit. Arizona has talked about a 5-year limit a few months back, and they were looking at possibly approaching the federal government. The limit, this is, again, when I say out of the box, this is not Medicaid expansion under ACA. Our out-of-the-box recommendation is pre-ACA expansion. It's a Section 11 at 15 waiver, normal match, unless you can negotiate a higher match. And we're going to show you the financial issues here. But this is an out-of-the-box, negotiated, we believe, with the next administration. But it's to take care of individuals at low income that need health care, but also need job skills and other readiness activity. So a lifetime benefit has worked in TANF and could work in this program as well. Your state, by the way, has a 2-year lifetime limit on TANF. 2 years. Much stricter than any state, most states in the country. So let's address the governor's 7 points. First, mandatory HIP. We've included that in our THIP recommendation. But you're going to need to enhance program integrity if you do mandatory HIP. We can talk about that. during the questions, and I can give you some thoughts, but our teams looked at that. You're going to have to increase program integrity. Premiums above 100% FPL. We would be a little different. We'd look at, instead of the premiums, if you follow your wellness plan, you don't pay premiums. Training referrals for unemployed, we agree. It would be a T-HIP. Same thing would be covered under our recommendation. Non-emergency transportation, we don't believe that you should eliminate that benefit. We have shown you in the findings the return on the investment for helping these people, individuals with transportation, far outweighs eliminating it. We heard from folks in the Delta how important the transportation is. And I went one step further and asked the department, has there been the same improprieties that other states have seen? I've seen audits in other states where they've used the transportation dollars to pay for bus passes, and CMS has audited and asked the state to pay back millions. No, you don't have the same problems here. And you've had an audit, and the audit came up with one provider. There were a few issues we looked at, nothing substantial. So the proof isn't there that it's being abused. Limit access to the provider market for non-workers. We did not include this. First of all, you would take a hit on the premium tax impact, so you'd lose revenue, significant amount of revenue. And we think it's good that you're focusing individuals to be in the marketplace rather than in the Medicaid program. So we think you should stay with a larger marketplace pool. Cost savings in traditional Medicaid, we've included them in our recommendations. Strengthen program integrity. Those are all included in our recommendations. So we've addressed the governor's 7 points in detail too in the recommendations. At this point, we're going to talk about SHOP, because SHOP is something that some of the members may not have heard about, some of you have. We really think this is an opportunity for you. And when we talk about SHOP, we can address questions more this afternoon, and Stephen is prepared to answer questions. But bottom line with SHOP is the federal government is going to allow you, your employers, to use the exchange for subsidies for employees up to 50, but it's going to now be up to 100, change at the first of the next year, up to 100. And they're going to be able to receive subsidies for low-income employees if you hire a certain number of low-income employees. So we can talk more about that. You're going to get some tax credits, but we think that SHOP ought to be used, and this is where we think you should focus on your 1332 waiver. And you could then offer some more tax credits for employers that go beyond 100 employees, and that requires a waiver. And you may be able to even talk about possibly waiving the EHBs at some point, 2017 and beyond. But it's definitely an option you want to leave on the table, and we wanted to provide it for you. But I'm going quickly because I know we want to get to some of the heart of these recommendations, and it's taken time, and I apologize for that. Building the 21st century Medicaid program. So we're going to talk about a cultural shift here, from paying claims to paying for performance. So first is an independent clinical assessment. We've talked about using evidence-based, state-of-the-art tests. Strong contracting provisions, robust monitoring system, ensure beneficiaries get high-quality care. Overall commitment to paying for care in least restrictive settings. Efficiently pay for value of outcomes through pharmacy benefit and a system-wide dashboard. So here are your alternatives, in our opinion. We've talked about them at length. So I think this is probably slide 38, if you keep going back to, and you want to talk about a decision tree. Slide 38 really gives you what we think is probably a really good visual decision tree. Your care management approach, your hybrid approach, and going to full risk managed care. And even when you go to full risk managed care, if that's where you choose, states have required the managed care companies to embrace patient-centered medical home within managed care. So you can even require that during the contracting. And we'll talk about that. So, Mr. Chairman, I know we're getting close to time, 11:30. There's a couple options here, because this is now getting into the heart of the recommendation on the traditional Medicaid program. I can continue going without passing off to folks on my team that I really want to dig deeper. I can wait, we can wait for the questions and have some of them and all of us address the questions, because I think we're probably about, maybe 20 minutes or so from coming to a conclusion on the slides if I just continue.
I think we should go the next 20 minutes, then we'll break for lunch, then we'll come back in an hour and a half, and then we can start the questions. Does that sound like it flows?
It works for us.
Does that work for the task force members? Stick a hand up if anyone has a big problem with that. I don't see any hands. All right, so we'll just plan for you to continue for
Okay.
another 20 minutes or so.
So we're going to talk about expanding the payment improvement initiatives into high-cost areas, elderly and physically disabled incentivized to place individuals in the least restrictive setting, payment methodologies about value, also allow your federal qualified health centers to be medical homes. Add upside cost sharing for situations where average costs go above targets and thresholds. Rescind the episodes of care for primary care and incorporate the corresponding measures and goals into the patient-centered medical home initiative. The one thing I forgot to mention, and I will say with regard to the alternatives, is I want to talk about the independent agent's role. I just want to raise this because we had the benefit to have a conference call and to meet with independent agents in your state. You have independent agents that work for the carriers that get paid, I believe, somewhere around $12 per member per month for everyone they sign up. They're having a real hard time with the eligibility system, and it's taking a lot of time, and they're providing the education. They're helping to map the system for the individual. What we heard clearly from them was lack of good communication with the department, collaboration. They want to be a partner. And in part of our recommendation, we suggest that the carriers, working with the independent agents, are the vehicle that provides a lot of that education and health disparity training and help in the future. And you may want to look at that, and I wanted to make sure I address that because those independent agents out there all over your state provide a very vital part of ensuring care coordination. And I know they want to talk to you at some point. We've had a lengthy discussion with them and heard a lot of great things that they do. So, integrated full risk managed care. All beneficiaries carved in. This would be one strategy. Everyone, what we would call all in. It's what Kansas did. It's what Texas is doing, because the last thing in Texas is development disability. Everybody else is in. Tennessee is long-term care. Mississippi started on the other end and is actually moving into long-term care. Focus the entire contracting approach on population health status. Identify improvement scorecard as a function of the RFP. Identify populations covered by the high-intense care coordination. The managed care companies have sophisticated tools to stratify and identify which individuals, which are the top 5%, which are the top 10%, real time, and they have a response real time that you don't have here today. Require that the state set aside, there's a state model where the state requires on the MLR set aside a certain amount where they only can make a certain amount and they gain share with the state, so a certain amount goes back to the taxpayers. It only can make a certain amount of profit. You can cap administrative services. You can identify that all in the contract. We've actually put in our recommendations. We looked at the best of the best, which you have the benefit of looking at what's working in other states and what isn't. And we have a list of MCO readiness for the department to look at if they move in this direction. On what are the key things for the managed care companies. What are the key readiness you need for CMS in the community? You can cover the whole state. We feel that your state, you would cover the whole state with an RFP. You don't want to separate it, regional. It probably is not the best way to do it because you have a lot of rural areas as well, but they're covering these areas in every other state. And they know how to manage this population. They bring the best of the in-state focus to the table. Require any willing provider with allowance for the MCOs to reach out. Include all waiver services. and you would include those in the program. Include reforms of long-term care and RSPMI benefits based on stakeholder practices. Let them figure out, and they can, but have the right contract measures that where do we need to make sure we do proper utilization, and have a good mechanism to do complaints and appeals so that consumers are protected in their rights. Program integrity requirements clearly identified. You're not going to get rid of OMIG, but they're going to work closely with your OMIG. And it's worked very well in other states that way. And I said earlier, include patient-centered medical home in episodes of care. Require them to include it. And every one of them on the questions you asked said they would be glad to include it. In fact, that's how they operate. They like to operate that way because they're all about the community from what we have seen and heard. Alternative approach would take your ABD population, which is high cost, and just put capitated full risk managed care for just that population and keep the patient-centered medical home going where you are today. But make sure you have improvements to that program on value in contracting, which I know you can. Look at, other populations to have would stay in the fee-for-service, but there needs to be clear delineation here of hospital, PCP, and specialist requirements, because now you're going to be talking about two models, and physicians are going to get confused. So we need to be clear. We need to make sure that we help, or you help, those physicians in the department through that process, if that's where you go. And the other issue, too, is with regard to the managed care populations, is that you're going to require you can require these individuals to use in-state providers as first right of refusal. There's so many things that you can do in the requirement in the contract. But again, let them manage the care. Let them do the care coordination. It has worked in other states. And you're not hearing the stories that you heard in the 90s. We have visited Mississippi and talked to the department there. We visited in Tennessee, talked to Patty Killensburg personally. We've heard from the people in Texas. We've spoken to the folks in Kansas. You may hear issues in the community that there's concern, but everybody's concerned about changes in the program. But you haven't seen the quality. In fact, the quality metrics have all gone up. All gone up. But that can also happen with patient-centered medical home. Dental, very important. And when we talk about, before we talk about the patient-centered medical home, I want to go back to one point here. On the patient-centered medical home, when Mr. Norsworthy was talking to you about value, and that the nursing home administration was willing to do more value to help move people in the community, that senior has a nurse coordinator. That senior has to have a health home. That senior has to have something that you can make sure when the providers are providing that care, that somebody's overseeing to make sure that that care is coordinated properly as well. That can all happen within a medical home, health home model. With dental care, we're not suggesting it be different. It can stay the same course. Texas, the dental care is all inside managed care. So you can do two options. But you can carve it out to a third-party administrator. But here's the bottom line for us. Looking at the dental program, meeting with the Dental Association, looking at some of the data, identifying the access issues out there, we think that you need to have someone else managing your dental program. And the providers want that, the dental providers, the physician, the dentists. And we think you can also bring value there by requiring them to increase access, require them to make sure that there's not this orthodontia abuse that you've seen in other cases. Putting braces unnecessarily on youth. Texas found that to be an issue in our research, towards $1 billion+ recouped or being recouped by OMIG. Enhance program integrity. Have Delta Dental had given us a suggestion on third-party administrator, and they're in your state, where they would go out in the community have the health home model. There's the Texas providers, 2 providers that showed us some examples, and we didn't just want to listen from providers, we went and talked to the state. And then the state sent us the data. The dental program is working in the states where it's in managed care very well. There's savings, there's better access, and the providers are happy. at least the ones that we have heard from. And the focus is on prevention as well, which is really important. Focus on community-based care as priority. You're going to hear more about the independent assessment, the assessment tools across the program. Independence, important, even if you move to managed care. Enhance community-based care. Remove barriers to community-based care. When we first looked at your budget and saw $16 million for assisted living, and you look at the number you had for nursing home care, that immediately jumped out to us in our experience as, whoa, the assisted living is not utilized in the state. Why? What's going on? Start looking, then you find additional barriers. Home health's not being utilized. What is going on? To the extent it could. But you know something, it's not about providers and it's about the system, the rules. A lot of it is regulatory too. And so some of our recommendations, remove barriers. For example, if you're on the home health program in your state, you have a nurse that a senior now it fills out the paperwork, the level of care, and you've identified, you fill out the paperwork, and now it goes to the department for another 50, 60 days to be reviewed. Department comes and says, approval. Guess what? Home health starts to get paid that day. The home health provider is paid the day the department approved, not the day that that senior and that home health worker started working with that client. That's when they get paid. Guess what happens if you're in the nursing home? The day you fill out that paperwork, you get paid. There is a bias there, and it has to be changed. And that's what we're talking about here. And when you start looking at a number of rules and regulations, you find these things, and your focus and priority has to be community-based care as a priority. And if your division's culturally thinking that way, and the community's thinking that way, including the nursing homes, everybody benefits. Community first choice. I want to talk about that. I know you've heard a lot. We would like you to look at including community first choice option in an 1115 negotiation with CMS, but do not accept it as an entitlement. I will stress, do not accept as an entitlement. So yes, let's negotiate to get that 6% improvement. I have negotiated with CMS in the past and received benefits from them for states if you meet certain outcomes. Arkansas says, guess what, CMS? We are going to reduce reliance on long-term care. We are going to put more emphasis on community, and we're going to save this amount. And in exchange for doing that, we would like to be given at least some of those savings to be used or an enhanced match. Make it part of the negotiation, but we are not going to agree to another entitlement. That is what our team believes you should look at. Rebalancing long-term care. Stephen's going to talk about that briefly. Very important slide.
So this is on slide 45. This is a projection of what it could look like if certain policy changes were made that caused a rebalancing of long-term care in favor or toward the community. Currently, the spend in Arkansas for the elderly and physically disabled population in receiving long-term services and supports is about 2/3 for institutional care and about 1/3 for community-based care. Looking at this table, if we look at the estimated 2015, you can see the percentage of all LTSS spend at 65%. That total cost there is about $760 million annually, or it was in 2015. If we project out at the 5% growth rate that is inclusive of both rate changes and population changes, that gets up to about $1 billion annual spend on nursing facilities. If over those 5 years, at 2017 to 2021, instead of maintaining the spend at 65% institutional, we incrementally shift it to about 50% institutional, which is about the national average, those numbers change significantly because the average cost of community-based care, including both the direct program costs and the additional medical spend, which we sometimes refer to as the halo cost, is significantly lower than for institutional care. So if over those 5 years we see a shift from 65% of the spend being in institutional to only 50% of the spend being in institutional, then we net a significant cost savings.
And we'll move into enhanced program integrity now. We are recommending that you look to create what we're calling an enterprise benefit integrity hub. And that this hub would be housed at DFA because we feel it may in the future involve other state services, state benefit structures. And what it is, in a nutshell, would be like the state of Florida is as an example, where you need, if you go on for benefits, and you're looking at an alternative to private option, you go into whatever your future benefit is, you're going to then be taken to this hub where your Social Security, date of birth, name is going to be matched into a database, and then you will identify whether that individual at that given time is a state resident, whether there's some other identity issues, and if there are, our suggestion is you merely do what the state of Florida does, and you now have to go meet with a case manager. And here are the issues, you just need to meet with the case manager. That benefit integrity hub, if it's done the right way, in our opinion, will save your state millions of dollars. And it may cost something to put it in effect. And if done properly, will be integrated into your eligibility system. And may need some waiver authority, because in one state, they had to get waiver authority on the food stamps for the certain questions that they had to ask before someone would be given the ability to go into the portal for food stamps. And it's all automated, real time. You pass the test, you get in. And we think that this is something that could be innovative and set Arkansas in a different area than most states, because most states don't have this. Even in the states that we mentioned on managed care, we've asked questions. What happens to the managed care companies that are getting paid a PMPM for people that are moving out of state in Tennessee, Texas? They're moving into Arkansas. What are you doing? Well, we wait for the yearly redeterminations. This is what happens in your state. This is what happens in every state. We're saying you go to CMS and you say, we are not going to do this is key. We are not doing redeterminations in between 1 year based on your rule. Your rule says you can't do them any less than 1 year. We don't want to waiver from that rule. What we want to be allowed to do is say this. If we have a flag in the system that says someone is possibly not living in this state, we want to then send a letter out, a notice letter, and provide the 30-day notice and all the required notices to that address that what we were given to see if they still live at that address. If that person has changed his or her address and didn't tell the department, which is a requirement under federal law, then that PMPM payment stops. And today, they're just going out the door. And they're going out the door in managed care states all over this country, because states haven't even figured this out. And this is something we think very important to your program integrity. And the good news here is OMEG has already started moving down the road of a PAPD, Planning Advanced Planning Document, which is required to get federal dollars to change systems. And they received federal approval. And as I was reading the letter said, let us know by the end of December 2016 if you want to amend this PAPD. Now you have a roadmap here where you could go to the federal government and say, we want to create this hub, we want some funding, here's what we think it's going to cost, and you could start to deploy that at DFA. And the reason I say DFA, you may want to do this later for unemployment benefits, because there is an issue of unemployment fraud throughout the country as well. And in some states, they've used integrated systems like this for unemployment. So anyways, it's all fully fleshed out in our recommendations. Automated income checks. Automated income checks. The one issue on income, and Jason, to his credit on our team, I asked Jason if he could find a way with the income eligibility folks here. if he could take the data we were given by for the private option and Medicaid, match it up against workforce income data that's used today, and are there hits, and how many hits would you get per quarter? If you were to do that on a quarterly basis, you'd get a couple thousand hits of changes in circumstance moving up, not down, moving up. But again, in Arkansas, you wait for that 1 year and you do the redetermination at the end of the year. If you were to just do automated checks on the income like that and simply sent the letter out, and it generated the letter at that point, which is much more, and Senator Ingram's question here about how can you make it more orderly on the redetermination, that's orderly. That letter goes out, notice, 30 days, right amount of time, explain, if we get the right information, that alone will save you about $8 million a year if you were able to deploy that system and it was working effectively. Support Medicaid Inspector General in building their enterprise fraud program. Organization, key principles of the future organization. More emphasis on collaboration across Medicaid, more emphasis on vendor oversight, evaluation of healthcare policy, planning, and innovation function, or elevation. Again, we've talked a lot about value. New staffing model, focus on performance management. We've given you some ideas in the recommendation on what a staffing model could look like. Help the department with the resources they need to make it work. Eliminate 1,000-hour cap for contract personnel. Martha can talk about that later. There's also ways on procurement where you could have get on a state list, go through the RFP, get on a state list, and then be able to be a chosen vendor so the department doesn't have to go through a lot of time and effort to try to get someone to help them. Again, if you have to feel comfortable, though, that you have the folks that are going to be able to watch that from the integrity standpoint. This slide 48, this is a new organizational structure. It's in your recommendations. What you will see here is a very streamlined, this is a health plan. This is an idea we got from the state of Tennessee. Tennessee runs their organization like a health plan runs its business. And complete integration throughout those populations we talked about. There would be a Medicaid director who would have a deputy who would be like your COO, and all the operations would report to him or her. And the Medicaid would be much more elevated than what you have today. And they would be ultimately responsible for a lot of this and could report to the Department of Human Service director as well, depending on whichever way you would want to go. And again, these are just some thoughts. There could be a lot of different angles here. But the important thing is to look at the integration along budgeting, finance, policy. And some of this is already happening at your department, so you'll just have to compare from what their current organization structure is. But vendor management centralized. People know where to go for all contracts. And you have someone that reports to you. And if you need data and analytics, you know there's an IT shop and a data analytics shop that is ready and capable. That's centralized. There are a number of contract changes we recommend, and I want to give credit to the department for meeting with Martha, Richard, and I, and taking a lot of issues that are very difficult to look at all the contractors and how much is being paid out and trying to make sure we can do everything we can to find areas for you and the department, the director, to reduce contractual obligations and liabilities, to help get the $50 million the governor is talking about, to help some of these providers that are getting lower rates, to do whatever we can. Where is some of this that can be renegotiated and cut from the top based on our experience? The department came forward number of times back and forth, number of trips to go over, are we right here? And we finally came down to a spreadsheet that they pretty much have accepted and agreed to, and Martha can talk about that later, and we've included that for you to look at from the top 25 contracts. But we didn't even look at the other contracts under the 25 because we just didn't have all that opportunity and time, but there's many more. But the top 25 is where we focused. And within that, significant savings opportunities. I know some folks behind may not like to hear that, but you know, at the end of the day, You shouldn't be paying 30% indirect costs. 30%. I mean, that's a lot. But who's watching to make sure that doesn't happen? Who's saying, we're not going to pay more indirect, some states 5%, 10%. That's it. And that's where you have to really focus on. You've got to trust that the resources that the department has is going to make it work for you. So we've seen a lot of areas where we can improve. Overheads, shifting some of the costs. The department's already moving forward to shift costs into the new MMIS system, and they are looking to find efficiencies. But they can do better in terms of having those opportunities and resources, but renegotiate. So here's what we would suggest, and we talked about this in the findings, in our recommendations, actually. Advise the department to work with the vendors and begin renegotiation of some of these contracts immediately. You can't wait, in our opinion. If we could find another couple $1 million by doing something differently, let's do it now. That's our advice to you. And yes, some may want more, and that's going to be part of the negotiations. But the providers will be out there, and they'll come to the table. We've had the Arkansas Children's Hospital in one of the meetings come to the table and say, we're willing to help the state, and here's what we're willing to return to the state this year from our rate, which they did. There are providers out there that are very willing to come to the table. They have to be asked. And in large respect, you can make a lot of that happen. And Martha can talk more about that later. The EEF project recommendations, hire a strong systems integrator. Restructure your IT governance. Some of this is being done now or looked at by the department, and they may be in the process already hiring an integrator, but very much needed. Jason can talk to you and Martha about why we feel that's important. Fixed price contract system development. Use the fixed price contract system for development and services, which is something, again, Martha will talk about. Very important, some of these smaller recommendations, but they add up. And manage the development of the requirement for the next EEF procurements to be complete and accurate as possible. Recommended vendor management. Streamline the procurement timeline. Institute a program of state term contracts is what we talked about. Develop a consistent approach to tough performance indicators. Manage contracts through the performance indicators. Effectively use performance data across agency. Across agency. Now, what do I mean? I'm not sure, and I'm not suggesting this doesn't happen today in Arkansas. But just an example, in one state we were working in, so they have dental managed care. Dental managed care finds that a child has significant dental problems. Significant care, which you would classify as abuse. Abuse. Has anyone contacted Child Family Services? If there's data available that's being used in managed care, and some of it can benefit child services, you've got to figure out a way you can use that data to the benefit of your department. There's a lot of data out there, and we're talking here about managing that data so that the value and the outcomes can be met for the department. Pharmacy recommendations, Rory will get into this much more detail. Renegotiate retail pharmacy network, increase the use of pharmacy lock-in, add prescriber locking, allow DHS clinicians access to state prescription monitoring program, eliminate pharmacy claim limits for maintenance medication, expand the PDL, consolidate outsource call centers. There are others, retail network recontracting. We've identified some savings. I'm gonna have Rory talk about that after the break. And here's finally to recap on additional considerations. So these considerations are important because we felt it important enough after looking at everything to give you some other additional thoughts. Improvement in vendor management we talked about. Healthcare facility liability protection. I want to stress this. Healthcare facility liability protection. Some states have a system in place. If I come to a nursing home as a compliance certified CMS certification process, I work for the state, and I'm going down to that nursing home and I ding them because I see something out of place, and it goes on the list. Lawyers in your state are using that against nursing homes in settlement agreements and discussions. Some states do not allow compliance, regulatory department information like that to be used in any lawsuit. That is something you need to look at, because those nursing homes are concerned, and what's happening? It's driving up healthcare liability costs. It's driving up the cost of care for that individual, and it's costing the taxpayers. And we do mention the issue of tort reform. Some states have looked at it, but that's an additional consideration for you to look at. But the bottom line is this liability protection is something other states have done, even with or without tort reform. It is driving the cost up, and we continue to hear it when we meet with providers. A commission on the future of your human development centers. We have heard from the families. Richard was with Representative Meeks yesterday at Conway, and it was a great visit. And we have heard the quality of care in these centers. We know this issue. We have been in other states where this is a very difficult issue. But we also have seen quality of care in transitions and families meeting their needs, and we've seen so much positive happen. What we're recommending is that you, the healthcare, take the lead, a task force take the lead, create a commission that looks at these facilities, because your cost in upgrading these facilities in the next few years is going to be so high. And we've seen a recent report to the department. And you've got to make sure these families and their needs are taken into consideration, and you have jobs in the community. And how have other states transitioned these jobs into the private sector? How have they done this successfully? Create that commission, and we've given you a structure, and one of the appendices has our thinking on all the ideas, the indicators, the issues that this commission ought to look at in terms of quality of life, quality of care, family transition planning. And your commission can use that as a starting point. But at the end of the day, decisions are not going to be met with approval by everyone, but they have to be made. And someone's got to make them, and we feel that's probably the best collaborative approach. Involve providers, involve families. Collaboration across Arkansas universities and colleges. This is almost adding to Senator Irwin's issue of agriculture. There was a bill that passed last year that we saw on using the University of Arkansas agriculture to do more life skills. We are aware of other states, and we gave you two examples. Again, Mississippi, NSPARC at Mississippi State, University of Massachusetts, that has a great relationship. I have spoken to the dean at the business school of the University of Arkansas. I have also reached out to your director and his staff on this issue and these ideas. But when we look at the contractors in the department, and we look at a lot of project management, and you have your MMIS workers, and you have folks that are making a lot, but then you have data analysts these data analysts could be university, college graduate students. Some of them could do the same thing and be trained up to that point. You are not keeping good quality employees here in Arkansas. And the money is going out of state. We're included. But at the end of the day, you've got a University of Arkansas that has good quality students, that has a center of excellence in their system, not tied to healthcare. But you have other states that have figured out a way to develop a relationship with your Department of Human Services on staff augmentation. Mississippi has graduate students, private sector employees that work for Mississippi State. They house the data that's used for workforce department. They are able on state contract to be used and deployed when needed, and they bring students in, and those students, guess what? Stay in Mississippi. And that's one economic development that we wanted to raise with you, because we think it's a really good idea, because your department is not doing that in health care for the Medicaid program. And it's something they're very willing and open to that idea. We feel there's a clear backlog in long-term care determinations. Director Cloud is working tirelessly on this issue. We really commend him for that. And I think that they're working through that system. But make sure that backlog doesn't come back, because it takes time for you to pay providers. And if you're going to move to a community-based transition system, you need to make sure you're paying your providers promptly. Develop a strategy to address mentally ill and jail diversion. We've talked about that. I know Senator Rapert, your question last time, we dug, we looked at other states. There's a lot of opportunity there. And we have a recommendation for you folks on that issue. We have one idea that you create immediately a study group on the DRG methodology. Give them a certain period of time to come back to you and to look at what your hospital payment structure should be in the future. And Bob Chin's here, and he can talk about that later. We have met with the providers, the Hospital Administration Association. They advised us of some areas that we needed to look at in terms of supplemental payments, taking into consideration the enhanced share, what UAMS does in terms of helping the general fund, all these other payment structures and methodologies that all need to be connected. And we agree with that. But whenever almost every state in Medicaid is using the DRG methodology for payment for hospital, APR DRG for children's hospitals, and you're not at that level, one thing we recommend is you look at that immediately. What would be the impact? Put together a group, convene this group to come back to you in a short time and say, here's what we've identified. And if we move to DRG methodology, here's what we want to make sure that for the providers, or APR DRG for Children's Hospital. Waiver. We recommend a global 1115 waiver. And this has been done in Rhode Island, in California, and a few other states where they wrapped all their waivers into one waiver. You have too many waivers and state plan amendments and individual plans today that they have to manage all these waivers, all of them. So this is an idea that has been accepted by CMS. It would be much more efficient for your department. And then a lot of the things that you talk about in recommendation could be implanted in that waiver. And the global idea is to make sure, you also want to enhance flexibility. This is all through negotiation. The executive department does the negotiation. But if you establish savings, and I know that early on, the Surgeon General asked about block grants. There is no state that has a block grant for Medicaid. But a global waiver could be similar to a block grant in that if the CMS would allow you to use some of the savings to reinvest in the program, if you meet benchmarks, you could negotiate that, and they may be willing to. I'm not suggesting they would be. And you may hear after this meeting, by the way, oh, but CMS won't do any of this, and CMS won't. I've learned long ago everything's subject to negotiation. Everything is subject to negotiation. And a lot is on the table. And you need to make sure that you also leverage what you have here. Enhance and expand your flexibility. You need to have greater flexibility. If Director Seelig wants to move forward and say, we are now going to work with the nursing homes and create a quality incentive program for nursing home, and we're going to pay nursing homes an additional amount for taking care of that senior in the community, and we're going to, why do I have to get CMS approval? You know what? If it's not, come back, audit, do it, yes, they're given the match. But let's move forward and just notify CMS we're moving in this direction. Now, they may not like that, but they have approved similar notification in other states. Instead of every plan change, every rule, waiting, and it takes 6-7 months to hear from the federal government at times on certain changes. If you're going to move forward and be flexible, you need that flexibility. So we would recommend highly that you do everything you can to ensure within that waiver flexibility for your program changes. Reduce reporting requirements and bring accountability for success. If you're moving at 5% growth right now, and what Stephen said, if you go project out for 5 years, 17 to 2021, and you're at this amount, and if you make changes on patient-centered medical home, managed care, whatever you do, and you come in at this amount, and you got this much in savings off of baseline trend without waiver, and they agree to that trend, which 5.9% is what they've said, and they agree to 5, whatever it is, and we come in at 3, and you end up showing those savings, why can't you reinvest those savings into DD waitlists, into rates for providers, into other areas? That should be your prerogative. And that's where you should be in terms of your negotiations. So we're going to now end with the savings estimates. A lot has been said here. I want to just say These, again, are estimates. And we're trying to do the best we can here. It may not be exact, but it's going to give you ideas on decision-making.
So I'm now on slide 57 with savings estimates from different potential models. These several different scenarios mirror the different models that John talked through earlier. Looking at this table, the first line is the baseline projection using the 5% growth assumption. Scenario 1 is assuming that all of the both high-cost and low-cost populations go into a much more aggressively managed fee-for-service environment. Those savings against the baseline, the numbers there are savings against the baseline trend. Those assume that we have already captured some of the savings from managed fee-for-service through the existing scope of the PCMH and episodes of care models, but that there is still some additional savings that we can potentially gain by expanding that into all populations and all recipients. Scenario 2 there is managed fee-for-service for the low-cost populations. That's generally the pregnant women and kids, and then capitated managed care for the high-cost populations, your elderly, physically disabled, developmentally disabled, and individuals with severe and persistent mental illness. There we have several lines as opposed to just one line. The top line in that block is the direct program savings or projected program savings. The next line is the premium tax, because with that capitated managed care there is premium tax receipts. And the third line is the sum of those, so the impact on the state fund from that level or that scenario. And then the third scenario is all populations into capitated managed care. There we see total all-fund impact over the 5 years of about $2.4 billion. That's direct program savings and premium tax receipts. I believe that you've received a handout of the graphic of these projections. That was meant to be in a slide, but it, for some reason, didn't convert correctly. But that projects out, that's just a graphic representation of the table, a projection out of those several different scenarios.
And we can address those during the questions. And the final slide is, if, again, using these other state experiences, it may not mean that it's going to happen in Arkansas, but it gives you at least some ideas. But no matter what happens, our recommendation would be that you can even put this in law as well, that certain reinvestments be looked at. If you achieve those benchmarks and savings, that you look at DD waitlist, that you do similar to what Kansas did, that you look at rate enhancements. Some of your rates are very low in the community, especially in the home and community-based area. Some of your physicians in your state, when the physician rate increase no longer was in effect, did receive a reduction. There are issues there to restore them. There are issues in additional investigators possibly being needed for program integrity. And there are issues involving employment support and others. What we think that you need to look at is, if you meet those targets, that you also don't forget that you need to give the department the resources it needs to make this happen. And without that, and without making those changes, you know, it may not work as effectively as you would hope. With that, we can answer questions this afternoon.
That sounds wonderful, John. So we're going to break for lunch here till 1:30. I just want to tell you personally, I really appreciate the work that went into this. It's quite evident, not only today, but throughout this process. And so thank you so much. Comprehensive, lots of food for thought, bold, all of those things. We'll reconvene at 1:30 for questions.
Oh man, I'm tired.